Okay, so we are going to do OMT 101. This is the first module that we will be completing in the OMT sequential curriculum. So we'll get started here with osteopathic whole health OMT 101. The philosophy of osteopathic medicine kind of surrounds four basic tenets. The body is a unit, self-regulating and self-healing. Structure and function are interrelated. In other words, if structure is abnormal, it leads to abnormal function. And if an organ function is abnormal, it will lead to structural abnormalities. And then rational therapy of any kind is based on these principles. So when we look at the somatic dysfunction in osteopathy, as the introductory palpatory and OMM language videos that you viewed kind of summarized, it involves the body's framework. In other words, the joints, the bones, the muscles, fascia, vessels, and nerves. And it's diagnosed in most part by palpation of the TART findings, which are tissue texture changes, asymmetry, restricted ranges of motion, and tenderness, all of which are found on your physical examination. Somatic dysfunction arises from macro trauma and micro trauma. Examples of macro trauma are accidents, childbirth, major surgery. Micro trauma being gravity, posture, and stress. Not every dysfunction must be corrected. Target your treatment on what contributes to the pain or impaired function. So when you find a somatic dysfunction, it doesn't necessarily mean it's causing a symptomatology or pathology. You have to look at the person as a whole. So when you're looking at the palpation skills, you're going to find acute and chronic changes when you're palpating. The chart here describes the difference. Acute changes tend to be sharp tenderness, erythema, warmth, bogginess, edematous, swollen tissues. Example here you can think of, an extreme case would be a swollen ankle from an ankle sprain in the acute phase. And then, when you're looking at chronic tissue texture changes, you're looking at dull parasitic tenderness, pale, cool skin, ropiness, bogginess that's kind of fibrotic instead of swollen, and fibrotic tissues. Palpation, getting good at it takes a lot of practice, but we will touch on instrument-assisted palpation here in a little bit. To make a somatic dysfunction diagnosis, you need two of those four criteria on physical examination. If you have two of the four of those in any region, you have a somatic dysfunction. So this is a concept that often gets some folks frustrated or confused that are new to osteopathic principles. So basically, you want to start with the idea that there are several barriers in a human range of motion. So you're looking at anatomic barriers, which by definition, an anatomic barrier usually is elicited by passive range of motion. In other words, you're out here at the barriers anatomically, and that is what the patient can, for instance, rotate their head back and forth passively without any assistance from anyone. So I just said that completely backwards. No, the anatomic barrier is the limit of passive motion. So you are moving the patient. Okay, so if you are anatomically approaching an anatomic barrier, it's the provider that's doing the range of motion. Now, opposite of that is the physiologic barrier, which is the patient is moving themselves. And the physiologic barriers here and here live within the anatomic barriers. So even I get confused with these. So anatomically, those are the end range barriers. Those are the ones that if you exceed these barriers, you will fracture someone's bones, you will tear a tendon. In sports injuries, if athletes exceed the anatomic barriers, they will have a meniscal tear, uh, collateral ligament tear, that sort of thing. So you don't want to exceed the anatomic barriers. The physiologic barriers are the patient's active motion that they can do. And then your restrictive barrier is opposite the somatic dysfunction, and it lives within the physiologic barrier. So a restrictive barrier would be if I can only rotate my head this far this way, but I can go all day this way. So I would be restricted in right rotation. In that case, the somatic dysfunction, which is named for the freer motion, is rotated left. So always think of it one of two ways. Either think restricted or somatic dysfunction. So they're always opposite. Somatic dysfunction is the freer motion in whatever region you're testing, and a restriction is the restricted motion. So you can look at it one of two ways. You can be the kind of person that feels the restriction easier, so you just say, okay, well that's definitely restricted in rotation to the right, so it's rotated to the left. I mean, somatic dysfunction is rotated left. So I always look at it that way because it's easier for me to name the restriction first and make the somatic dysfunction opposite than it is to name the freer motion and name the somatic dysfunction with the restriction opposite of that. So another big key point here that we have to touch on is the autonomic nervous system and homeostasis of the human body. Um, the um, the big issue here is that the sympathetic nervous system arises from the first thoracic segment to the second lumbar segment, give or take. Everyone's different, but that is the textbook definition of where the sympathetics arise from. So when we are looking at uh, organ systems that cause somatic dysfunction, such as the heart, um, and we want to affect the sympathetic innervation to the heart, or a heart patient is having a viscerosomatic reflex to the thoracic spine, we're going to look at T1 to T5. Those segments we'll review here more in detail. Parasympathetics, cranial nerves 3, 7, 9, and 10, and the sacral 2 through 4. So key OMT goals here are to normalize sympathetic overactivity. Examples of that, we use rib raising, paraspinal inhibition. We like to support vagal tone by working on the OA, the AA, and the suboccipital release techniques. We like to enhance pelvic splanchnic nerves with sacral rocking and inhibition techniques. And we like to optimize lymphatic and venous return by working on the thoracic inlet, the diaphragm, and using lymphatic pump techniques, all of which we will review. And if you look at this nice little summary over here, it will give you some idea of the parasympathetic divisions of the cord and the sympathetic divisions of the cord, and kind of an overview of the end effect they have on some of the organs. This particular diagram right here is a staple in osteopathy. So pretty much this is something you want to sit on and have some time with, okay? And actually study this because it'll tell you by organ system, it'll tell you the sympathetic spinal levels that we would target with osteopathic manipulative therapy, because this is the spinal levels that the sympathetic innervation comes from to that organ, and the parasympathetic source as well. So for example, the liver and gallbladder issues, sympathetically we would target T5 to T9, especially on the right. And cranial nerve 10, which is the vagus nerve, for the parasympathetic tone of the liver and gallbladder. It tells you the effect of sympathetic tone, parasympathetic tone on that organ, and then gives you some clinical osteopathic pearls that are pretty much classic findings. This chart is another way of looking at that. And it goes by organ system up here, sympathetics here, parasympathetic effects here, and then lymphatic effects here. And I put these in here just so that you would have a different way of looking at it. Whichever one of those you prefer, just spend some time with that and review that so that you understand whenever we're building these sequences and we're going over these treatment sequences for OMT, for such things as hypertension, coronary disease, you understand why we're treating the areas of the spine that we're treating and what our intention is with targeting those areas. Okay, so OMT continuum is a concept that I've developed over the years. Many others have as well that have done this uh, for quite some time, and that is you always start with the soft tissue counter strain, instrument-assisted soft tissue manual techniques, and then you advance to the myofascial release, the facilitated positional release, still techniques, muscle energy, articulatory, and then HVLA to patient tolerance, and if you need to correct the somatic dysfunction. So we're going to look at these one at a time. But when we build these sequences and when we train you on these sequences for the different things, these are the core techniques that are going to be in those sequences. And it will be to patient tolerance as far as how far you advance in those sequences at any given osteopathic treatment. So the sequence aims to decrease the pain first and gradually restore mobility and function. It's okay to stop progression of treatment based on palpatory findings or the patient's level of comfort. So always get your patient feedback during the treatment. It may take many attempts for some somatic dysfunction to progress from soft tissue to myofascial release. It might take several visits to get them to tolerate anything past myofascial release, anything more aggressive in myofascial release. So soft tissue, this is a very much a foundational concept in osteopathy. We work on the soft tissues, the myofascial tissues. You can do parallel or cross fiber strokes to break adhesions. You can enhance the circulation. It prepares the tissues for deeper techniques, which anyone who does this for a living will tell you that's why it's so important to prepare the tissues and the myofascia before you try to correct somatic dysfunction that's on a deeper level, especially segmental of the spine. And you want to avoid overpressure, and you definitely want to um, respect any of the contraindications. These contraindications, we're going to outline here for your review, but fracture, infection, open wounds, they're all very much common sense. The next thing, strain, counter strain, myofascial release, and then facilitated positional release. Strain, counter strain. The first thing you do is identify the tender point, and you take it to a position of ease by wrapping that tender point. You utilize the range of motion to wrap that tender point. So if you find a point, you would flex or extend around that tender point, side bend around that tender point, rotate around that tender point until the patient gets to a point where they're down to it at 3, 2, 1, 0 would be perfect. Out of 10, pain on that point. You hold that for 90 seconds in that position of ease, and then you slowly, passively return that patient down to a neutral position. Myofascial release engages fascial barriers directly or eases them into an indirect position. You're going to feel for the glide of the tissues, and we'll show a demonstration of that here in a minute. You hold them until you feel that release, or that what we call myofascial creep of the tissues, and it balances the tension in the fascia and promotes normal motion. You have to remember the fascia lab that we did with the cornstarch and water demonstration. Remember that fascia is a solid that has liquid characteristics. So it is a very unique substance. So often a fluid, lighter touch will get you to be able to feel those restrictions more than an aggressive, quick motion. Facilitated positional release. This is a rapid neutralization of muscle hypertonicity by adding the compression force to myofascial release. You're going to move the segment into ease. You hold it for 3 to 5 seconds, and then you add a compressive force. It's very useful for acute pain because patients tolerate this much better than other techniques. Next on the continuum, you would move on to still technique. Again, this is basically the exact same thing as facilitated positional release, but you add a range of motion and engage the restrictive barrier while you're holding that compressive force. We'll demonstrate that here in 1 second. The next thing on the list is muscle energy. In this technique, it's a direct technique where the patient contracts against the physician's counterforce for 3 to 5 seconds. The patient then relaxes and while you reposition to a new barrier, you take it a little bit further. And again, you do the isometric with the patient. They utilize this post-isometric relaxation and reciprocal inhibition principles. And what that does is it will increase that joint's range of motion um, and really does relieve the somatic dysfunction quite well. The key here is dosing that isometric contraction, getting the patient to understand how hard you want them to push against you. This takes some training with the patient because if they don't understand the dosing, I usually stop the treatment and go to a different modality. I'll go back down to facilitated positional release, counter strain, something, because if they're dosing it too forcefully, you can actually make them worse or cause spasms during the treatment, which you will experience. So this is a very good, useful technique. It's a very common technique, and we'll demonstrate that here in 1 second as well. After that, you have some articulatory techniques, which is a low velocity oscillations through ranges of motion. Um, so you take and you engage the joint with this fluid oscillatory motion, engaging flexion, extension, side bending, rotation, um, all through its ranges of motion, engaging it actively through direct and indirect approaches, hence the articulatory. So you want to prepare the tissues very well with soft tissue and some myofascial, even some counter strain before you use these articulatory techniques because they do exaggerate the range of motion quite a bit, but they're very effective, especially for the cervical spine. We'll demonstrate that. The high velocity, low amplitude techniques are short, quick thrusts through a restricted barrier. They're direct techniques, as direct as it gets. And I would offer that you should only employ these after you use earlier techniques in the continuum to prepare those tissues appropriately. Contraindications include severe osteoporosis, spinal instability of any kind, infection, or malignancy. Got to be careful. So clinical sequencing is very important. Be purposeful with the patient selection for OMT and the technique selection on your sequence. In our modules that we will be teaching and you will be learning, there are 5 to 7 techniques in each sequence to be done or approached in order for any given condition. And that too, we will train more on as the time goes on here. But I will be demonstrating now the techniques here in 1 second.